Hi, my name is Dr. Chang, and I'd like to welcome you to this introductory video on Barrett's esophagus. I'd like to discuss with you what Barrett's esophagus is and the risk of a patient with Barrett's esophagus going on to esophageal cancer, and also to talk about what are the current options and strategies for treating and getting rid of Barrett's esophagus. So what is Barrett's? Last time I spent a whole hour on Barrett's, but this time I'll just summarize that Barrett's is the precancerous condition resulting from GERD, which then leads to esophageal cancer. So this whitish area is normal, but this more dark color mucosa is Barrett's. So it's really a transformation of the cells. The cells gone awry, and the cells look like intestinal cells as opposed to looking like esophageal cells. So why do we care about Barrett's? Well, of all the cancers in the United States, most cancers, including breast and lung, are flattening out and trending downwards. The one cancer that is rising at an alarming rate is esophageal cancer. And if you look at from 1975, where there was an incidence of 1 per 100,000, it's increased now to tenfold. It's about 10 per 100,000. So there's been an alarming rise in the incidence of cancer in the esophagus, and everyone is asking why. Is it because there's more runaway GERD? Are these PPI medications responsible? Why? And one of the whys is also the trend in obesity in the United States. Again, if you look at 1974 to current, we see that the first shaded area includes the overweight patients, and then up to the green is overweight plus obese with a BMI of greater than 30. And then the last layer is extreme obesity with BMI of 40 or greater. So if you count overweight, obese, and extreme obese, 70% of our adults in the United States are in this category. And if you just look at obesity, BMI greater than 30, every state in the United States now has 30 to 35% of adults have BMI greater than 30. That is an epidemic. If you go back to the map of 1975 to now, every year it's uptrending. So it's a very, very alarming trend. And people feel that one of the reasons why esophageal cancer is rising is because of the obesity. Now, whether obesity leads to more GERD, which leads to more Barrett's, which leads to more cancer, is possible, or obesity in and of itself being an independent risk factor for cancer is also felt to be the case. Now, one of the interesting things is this concept of central obesity. So if you look at just BMI itself, BMI can predict a higher rate of esophageal cancer. But if you look at what's called central adiposity, that even correlates higher with the cancer rate. So central adiposity is the midsection is wider than the hip. So this is an apple shape, where this is the pear shape where a lot of the weight is carried in the legs. So these folks don't have that as high as a risk, but it's the central obesity that really carries the higher risk of various cancers, including esophageal cancer. So now we're doing more what's called waist versus hip ratio. We don't want to ask you what yours is, but that is something that we look at when we assess patients' risk for cancer. So how common is precancerous Barrett's? Extremely common. 5% of the US population. Our veterans always do it better. 13% of the VA population have Barrett's. Barrett's is precancerous. Like Dr. Jekyll and Mr. Hyde, there's a sequence of transformation from normal and then stepwise until cancer. And so when patients come to see me, I talk to them about Dr. Jekyll and Mr. Hyde. A lot of our young patients don't know who Dr. Jekyll and Mr. Hyde is, but yeah. So anyway, we talk about the fact that there are 3 stages of precancer before you get to cancer. Stage 1, 2, and 3. And depending on which stage you have will determine your 10-year risk for cancer, 3%, 50%, and 100%. So it is important that we assess the Barrett's, take biopsies, and look at the cells to see how far gone have the cells transformed and be able to treat when it gets to stage 2 and 3. So this is an hour talk all by itself, but I'm summarizing it here. The Barrett's can only be detected by endoscopy and biopsy, and endoscopy can help determine the stage of the Barrett's. And Barrett's with dysplasia, meaning the stage 2 and 3, should be treated, and with a high chance for cure if you receive treatment. So we have really effective treatment now, whereas back 10, 15 years, the only treatment we had was take out the esophagus, which was barbaric. Even early esophageal cancer now can be treated and cured by endoscopic technologies. But first, let's step back and talk about what the best way is to detect and stage Barrett's esophagus. Let me introduce you to 3 common technologies that we use in Barrett's patients. First, narrowband imaging, or NBI. On the left is routine white light, and on the right is the same exact image when we utilize NBI, and we can see the stage 1 non-dysplastic Barrett's with greater clarity. Here we see that narrowband imaging, or NBI, is showing the high-grade dysplasia, or stage 3 Barrett's, with greater clarity. In some cases, we can use endomicroscopy to magnify down to the cell level to examine the cells even without a biopsy. Say, for example, this area may be of concern for stage 3 Barrett's or even early cancer. So just imagine this spaghetti-thin microscope probe being able to look right at that spot. On the left is the appearance of Barrett cells when they're at stage 1, and on the right is Barrett cells gone awry and becoming cancer. Another technology we can use is called volumetric laser endomicroscopy, or VLE. This thin balloon probe is placed in the esophagus, and the laser light spins around super fast and reflects off the surface, imaging the cells. 6 centimeters is scanned in 90 seconds, with 1,200 transverse scans taken and 4,000 longitudinal scans taken, so that one can essentially recreate a 3D mapping of the entire area of Barrett's. Let's go on now to talk about the treatment of Barrett's. Depending on the degree and extent of Barrett's, we will either be employing ablation strategies or resection strategies. For ablation strategies, we can either harness the power of heat energy using radiofrequency ablation, or RFA, or hybrid APC, which stands for argon plasma coagulation. Alternatively, we can use freeze energy with cryotherapy spray or cryotherapy balloon. For resection strategies, we have EMR, which stands for endoscopic mucosal resection, or ESD, which stands for endoscopic submucosal dissection. Let me show you what some of these look like. Introducing endoscopic therapies for Barrett's esophagus. Now, RFA uses radiofrequency energy, which is similar to microwave, to ablate the superficial lining of the esophagus where the Barrett cells lie. For longer segments of Barrett's, we can use the 360-degree balloon device, which can treat 3 centimeters at a time. For shorter length Barrett's and for touch-up treatment, we can use the smaller focal device. I guess I may have had something to do with the development of this device, as it is also called the Chang cap. One of the common heat ablation techniques is called hybrid APC, or argon plasma coagulation. In letter A, you see the Barrett's tissue. In letter B, I'm injecting a fluid cushion to safely lift up the Barrett's mucosa. In letter C, you see a thin stream of argon gas, like an airbrush, which then precisely transfers the heat energy to ablate the Barrett's tissue. Letter D shows the effect after one pass. Letter E shows another injection. Letter F, a second quick pass. Letter G is the effect of double ablation. And letter H shows what it looks like after healing. Now this is cryotherapy, which sprays liquid nitrogen over the mucosa, getting the temperature down to minus 196 degrees Celsius. Now that is super cold. And we freeze and thaw and freeze and thaw to ablate the Barretts. Alternatively, we can use a balloon catheter to spray nitrous oxide and bring the temperature down to minus 89 degrees Celsius. And lastly, we get to the resection strategies. This is endoscopic mucosal resection, or EMR, where we first inject a fluid cushion under the lesion, and then using a cap, we suction the lesion into the cap. This keeps the lesion elevated and away from the muscle, and then a snare or a loop is placed around the lesion and then cut or resected and retrieved. And finally, we have ESD, or endoscopic submucosal dissection, where in A, I mark the perimeter of the lesion. In B, I inject a fluid cushion. In C, D, and E, I'm making an incision or cutting around the perimeter of the lesion. And finally, in F, I'm going underneath the carpet and dissecting or teasing away the superficial layer so that the entire lesion can be removed in one piece. And there you have it. We've taken a fairly deep dive into the detection and staging of Barrett's esophagus, along with looking at the most current endoscopic treatment of Barrett's. Thank you for watching.